Good afternoon, everyone. So after having a talk on the urinary bladder, we'll go upstream and discuss about the various oncological factors in kidney. Starting with this session, I would like to invite Dr. Arvind Ganpule. His topic for that would be perioperative and functional outcomes following robot-assisted partial nephrectomy or nephron sparing surgeries. So on the stage, I would like to invite Dr. Ravi Mohan, Dr. Kamlesh Patel, and since Dr. Himang Bakshi is not here, I would like to invite Dr. Vipul. Dr. Vipul? So.
Good afternoon, everyone. At the outset, thank you very much, Uro-Oncology section, for this opportunity. I would also like to thank Intuitive Surgicals for allowing me to share this platform. I have kept this thing very simple. I will divide this talk into two parts. Part one is I am going to discuss some studies, one Indian study which actually throws light on robot-assisted partial nephrectomy. And then we'll try to discuss 3 cases and bring out some important points. I got a disclaimer that the work published and presented here over the next 30 minutes has been supported by grants from Intuitive Surgicals, and I'm a proctor and consultant for Intuitive Surgicals Inc. What we'll be discussing over the next 30 minutes is, as I said, that in the first 10 minutes, I'll be discussing on this Indian paper, which actually brings out certain important points on robot-assisted partial nephrectomy. And then with the help of the panel, I will discuss 3 cases. So this study that we are referring to has been done by this group, which has been nicknamed as Indian Study Group on Partial Nephrectomy. I will just give you a brief on this. This was an multi-center study which was done in 14 centers, and I'm privileged to have 2 of the co-authors to be on the panel today. Dr. Ravi Mohan, unfortunately, Dr. Himang Bakshi is not there. It has been done in centers of repute such as Rajiv Gandhi Cancer Institute. We have got Apollo as well as Max as well as at MPH, apart from all other centers. So this study was published in the Indian Journal of Urology. Basically, a total of 2,100 robot-assisted partial nephrectomy cases were compiled. Out of that, 782 were found to be evaluable. The study period was 12 years, and the following points were assessed: perioperative outcomes, functional outcomes, and oncological outcomes. There was nothing more significant, but one point that we found out in this study, that we found that the Indian study group found that partial nephrectomies were beneficial and had got similar outcome even in T2 disease. So this is in contradiction in what we see in the EAU guidelines and the AUA guidelines. And of course, the comparison of the based on the RNS score, we have done it, and actually there was no significant difference. I'll just allude to that further in the next 2 slides. I want you to focus on this point, that is the warm ischemia time. You see that the expertise in Indian surgeons has matured to that level, wherein the average warm ischemia time is 22 minutes. One more point I want to get your attention to is that if you see that the Clavien-Dindo classification, the grade 4 and 5 classification, grade 4 and 5 complications are not seen in a single patients that have been analyzed, and majority of the complications are Clavien-Dindo grade 3. One important point is that the positive surgical margin rates were 5.1%, and I'll be discussing that the standard one are ranging anything between 2.5 to 10%. Going a bit more into the analysis, if we go into the depth of the study and then try to analyze warm ischemia times less than 25 minutes and more than 25 minutes, what you see that the most important point is that the RNS score, of course there might be a bias in the way the RNS score was interpreted in this study, but as you can see here, if you can see the pointer, the RNS score in warm ischemia time of more than 25 minutes were seen in intermediate and high risk, high RNS score patients. And one more important point that I just mentioned is that obviously whenever the tumor size was on the higher side, the warm ischemia time was also on the higher side. A bit of more subgroup analysis, 2 points were very important as far as the outcomes were concerned. One was the warm ischemia time, significantly in intermediate and high nephrometry scores, and of course the operative time also, the overall wheel in, wheel out time also increased as the RNA score increased. An important thing which is actually contrarian is you see that the conversions were more in low nephrometry score and intermediate score. Probably the patient selection had got this particular bias. As far as the complication rates go, there were no deaths that were reported in this study cohort, and majority of the complications were clavin window 3 and 4. Just to give you a perspective, there are two important multi-center studies as far as partial nephrectomies go, and this is one study which I wanted to refer to is the transatlantic robotic nephron sparing surgery study. It is called as TRONS. This had got an study, the number of patients was 635, but as you can see, the surgical margin rates there were 3.8% and ours was 5.1%. In few of the study, it goes right up to 10.1%. But we attributed this particular fact to that why the surgical margin rates in those in that study were low, because probably they were high volume center and we had got an heterogeneous group of surgeons who were operating, and that may be the reason why probably our positive margins rates were on the higher side. Finally, how does this study make a difference to this crowd who has gathered over here? So unlike in the West, in India, there is no national or commercial database of clinical outcomes for surgical procedure, and that holds true for robot-assisted partial nephrectomy as well. To be very fair, there has been one study which has been published in the year 2022 as far as RAPNs are considered in India, and that was from Gopal Sharma. Gopal Sharma is the first author. And the Vattikuti database was actually accrued at that point in time, and from that a slice of patients were taken and they were analyzed. So the results that were seen in that study almost match to this larger study that we have done. But this is an largest collaborative study which is multi-institutional. So definitely it would be the way forward to take it in other realms of uro-oncology as well, because we have included 14 public and private tertiary care centers in this. As we just discussed, the perioperative outcomes in terms of warm ischemia time, complication rates, trifecta, pentafecta are all comparable as we compare them with the even transatlantic study as well. So this was a short brief on what I wanted to say on the study of the ISGPN group that we had done. I would like to discuss 4 cases which bring out certain points which actually were brought out in this study. So I would like to have the inputs from the expert panelist on this. So this was an 42 years old patient who actually presented with 2 episodes of hematuria one month ago, and the hematuria was painful, associated with clots. So obviously he was evaluated with ultrasound and CT, and that was showing an 4 by 4.2 by 3.2 centimeter lesion in the mid and lower pole of the lower calyx. So if we focus on exactly how the mass looks like, you can see that the mass is like so. It is an anteriorly placed mass, and it appears to be invading into the pelvic calyceal system. You can see it better here. It's not exactly invading but abutting into it, and there is an suspicion that it might be going into the renal sinus. So the radiologist will never tell you whether it's going into the renal sinus or otherwise, but they have reported it as mass effect on the PCS. So my question to Dr. Ravi Mohan is that the old teaching is that any hematuria is a contraindication for nephron sparing surgery. So if we go back into this picture, can we be very sure that number 1, is there any invasion of the renal sinus, and number 2, is it invading into PCS, and is it a contraindication for nephron sparing surgery?
I think the number 2 answer to the question is easy, that it is not a contraindication for NSS. But the first question, that whether renal sinus involved or not, I think we need to look in again, because presence of sinus involvement would change the stage and would also change the oncological outcome. So you need to be very careful before you decide for doing a partial nephrectomy, especially in a patient who has the other kidney which is normal, that if there is a sinus invasion based on the radiological discussion, then one might actually do a radical nephrectomy straight away. But presence of PCS invasion, or does hematuria always indicate that it's a PCS invasion? The answer is no to it.
Okay. Yes, Dr. Vipul.
Yeah, generally we do in that type of cases at HCG hospital, we do 3D reconstruction. If it is definitely involving renal sinus, we go for straightway radical nephrectomy. But if only partially calyx is involved, we can safely remove by the partial nephrectomy robotically with clear margin. So I think in that cases, it is better to take a call during surgery if there is no definite sinus involvement.
So I think we headed to what Dr. Ravi said, that we went ahead with an radical nephrectomy. The histology was clear cell RCC, and even the IHC report also proved the same. Retrospectively, Dr. Ravi, do you think that we have over-treated the patient, or we are fine with it?
We're not over-treated. I think we're fine, because at the end of it, radical nephrectomy is not like oncologically, it's still the best we can do to the patient. We're not over-treated. But yes, you could say that retrospectively, had it been a solitary kidney or we had imperative indications, could we have tried and partial? Probably yes.
Just in the hindsight, Dr. Kamlesh, suppose the final histopathology here comes as T3 invasion into the renal sinus fat. It's not here, but suppose hypothetically we consider in this case, because there was a suspicion when we saw the CT scan. So if this happens in the final histopath, what would be your take on that? How would you manage it further?
Then it is better to go for radical rather than to go for VAR.
No, if it comes in the post-operative period, what would be your line of thinking? How will you manage the patient?
I am not able to understand. What do you?
So,
I think your question is, if it is PT3,
Yes.
do you add any adjuvant
Correct,
treatment
correct.
to the?
Yeah, I would like to go for the adjuvant.
Adjuvant therapy.
I think up till now, 4 study, out of this 4 study, Keynote 456 only says that in a subset of group which fulfill the criteria of Keynote will get benefited from adjuvant treatment. Otherwise, there is no any clear-cut benefit where adjuvant will give benefit to the patient.
Yeah, I think one of the criteria is PT3A. So it's high-grade disease, PT3 and T4, T3, T4 disease, or grade 3 and 4 disease, where there is or presence of lymph nodes. There is a benefit of giving adjuvant immune checkpoint inhibitor for 1 year. That's what the study showed, that they would have a survival advantage.
So, will you, Dr. Ravi, will you accept that particular argument if I say that if it is a T3A, I will not do anything for the patient and just keep on observing the patient?
Yes, I would probably do the same, that we would keep him under observation, although because that evidence is not very robust. One second, it's very expensive. We don't know the tolerance and other stuff. So in actual practice, we would observe the patient, and whenever if he has recurrence in future, that is the time when we decide either we do metastatectomy based on the site of recurrence, or we decide for something else.
Yeah, got it. So here also, I mean, not in this case, but there were a few other cases where we just observed the patient rather than going ahead. So we go to the next case. This was a 68 years old male, diabetic hypertensive. On evaluation, he was found to be having a left-sided renal mass, and there were 2 small renal masses on the right hand side. And this was a picture on the left side. This arrow shows that it is a large exophytic spherical mass, 10 centimeter in size by 7.8 centimeter, extending into the perirenal soft tissue. While on the other side, you can see that there are these 2 small enhancing masses on the right hand side. So obviously we went ahead with an left-sided laparoscopic radical nephrectomy. So it was a 10 centimeter mass, unifocal, and this is something that I was really concerned about it, that it was a clear cell RCC, focal papillary differentiation, but more important, it was a sarcomatous differentiation, and the percentage was 5%. So I will come to that point. Rest everything, we did not see any rapid fever. One more important point I would like to highlight is that the nuclear grade was 4. And the CT scan was showing that it is going into the this thing, although it's not showing in the final thing, and it was extending into the renal sinus fat. Rest nothing was quite significant. The final P stage was PT3A N0, but sarcomatous differentiation. So a few points and a few points of discussion I want to bring out here are number 1, given the sarcomatous differentiation on the left side, how does it make a difference? I would like to ask all my expert panel as to whether the percentage of sarcomatous differentiation makes a difference in the management on the other side, or it doesn't matter at all. We can start with Dr. Vipul, maybe.
I think 2 important points. Sarcomatous differentiation and necrosis does make a difference in prognosis. So before go to opposition, I think we have to go for a genetic study. Patient might have an underlying hereditary renal cell tumor like VHL or underlying other variety.
And Dr. Kamlesh?
I don't think so. It's going to be change the line of treatment. We can go on the opposite side also with the partial. And if there is a sarcomatoid differentiation found in that, it is not mandatory that on this side, if we are able to find out the sarcomatoid differentiation with this 10 centimeter large mass, opposite side also we are going to find out the same. In opposite side, if we go for the partial nephrectomy and what kind of the histopathological differentiation comes, accordingly, we have to plan for the treatment.
I think I'll differ a little bit here. Left side, it's only less than 3, it's a very small tumors, right? And we know that it's a sarcomatous differentiation that is going to behave poorly, and it should actually be supplemented with some kind of adjuvant treatment. So if we are giving that, there's no need to do on the left side and the right side anything, because the moment you do it, you will end up with ATN and also loss of some amount of function. So in fact, those lesions might actually respond to the adjuvant treatment which you will give. In case they don't respond, in case they increase in size, then the question comes. And I'm not sure of the exact percentage as per guideline. I'm not sure exactly what is the percent, but to my mind, 5% is a significant enough to say that it is going to be bad.
Yeah. So any comments from the Aditya? You have got any comment? Aditya Narayan?
I might just said good pembrolizumab therapy, and probably I might go in for radiofrequency ablation of the masses and not a partial nephrectomy.
Yeah.
I wouldn't want the patient to lose his renal volume.
That is right. So that is my whole point. If we go for genetic study, if this patient has underlying VHL, so EUA guideline 2020-24 says clearly that less than 3 centimeter tumor on opposite side should be go on observation. If it grow more than 3 centimeter, then we go for partial nephrectomy. Rather than partial nephrectomy, it is better to do enucleation or radiofrequency ablation or other cryotherapy. Yeah. So here aim is to preserve the nephron, because this patient having a VHL, patient will die at the age of 42, in between 40 to 60.
Yeah,
So
your point is taken. I think Aditya, you have got something to say. Then we'll just wrap it up. Yeah.
I'm expanding on what Ravi mentioned. Adjuvant is required. The only thing is the intensity of adjuvant. You mentioned Pembro as a mono agent. In fact, most of the data for sarcomatoid and rhabdoid has been best with 2 agents. So Nivo EP has been most commonly used there to beneficial effect rather than single agent.
Okay, just in this case, I'll tell you what we did. That we have just completed a radical nephrectomy. We would also go more in lines in giving an adjuvant therapy and observe the other side rather than going ahead. But there was something that was going in my mind, that whether this patient requires a biopsy on the other side.
Yes, definitely require biopsy.
So yeah, Ravi, your opinion on whether we should biopsy the patient on the other side?
It qualifies for a small renal mass, but I don't think we should do a biopsy. What is the need for doing a biopsy? We already know that it's a malignancy on one side. I mean, how a biopsy is going to change? Let's say it's clear cell. Are you going to do anything? You don't have to do. It's less than a 3 centimeter lesion. You can actually observe, and anyway, adjuvant is going to act on it. So I honestly don't think there's a role of doing anything, any biopsy on that side.
So I agreed. So just to sum up, in this case, we have done a radical nephrectomy. We are observing the patient. We plan to give an adjuvant therapy and observe the other side. We are not planning for a biopsy or anything on the other side. We quickly go to the next case. This was a 71 years old male patient, no comorbidities. Again, he had got history of hematuria. One episode 2 years back, investigated with an imaging and found to be having bilateral renal masses. So this was the picture that we saw, that on the left hand side it was quite an exophytic mass. This is the lower pole, while on the other side again the patient had got an SRM. It is less than 3 centimeter in size, partially endophytic, partially exophytic. So obviously the patient, we decided to go for the left side first, because we thought that it's less than 3 centimeter, rather than biopsy or do anything, go on the left hand side first. So it was quite an uneventful procedure. We did a rhinography. After doing an rhinography, the following things were applied. Before we go ahead, Dr. Ravi, do you still practice using these hemostatic agents like Surgiflow or the newer one from Meditronics? What's your take on that?
We don't. I don't.
Verisat also, anybody has got an experience of using the Verisat?
I don't, honestly. I don't think in the audience you can ask, but I don't use.
So your experience is with Verisat? Yeah. Okay. So because I hear that Verisite is very effective. I don't have any personal experience on that.
Same here.
Yes. So coming back to our point that here though this is approximately 3-4 years ago, so we used an Surgicel bolster and we used Surgiflow, and after that it was quite an uneventful procedure, and our plan was that the patient will come after 3 to 6 months for the opposite side. This was the final histopathology. You can see that a rim of cortex is seen very well, all margins are free, and it was T1B Furman grade 2. So, as actually we will not be doing an CT scan so early, at 3 months generally we will not be doing an CT scan, but the patient was insisting that he wants to get the opposite side done, he wanted to go overseas or something, so we did an CT angiography. And the radiologist reports that on CT angiography, there is a small homogeneously enhancing, and he has written the enhancement from 53 to 120 nodular lesion at the operative site with a small pocket of collection. So your take on it, Ravi, as well as I would like to have inputs from Dr. Kamlesh as well.
Yeah, maybe Dr. Kamlesh. So, no, I think firstly 3 months you don't expect a tumor to come, especially when you have a good negative margin and a good amount of parenchymal rim which you had. So it's most likely some kind of pseudoaneurysm or some kind of collection. I'm not sure, because for pseudoaneurysm also it's not qualifying.
So what would be your line of management? Like
Just
you
observe.
Biopsy, observe.
Just observe. Just observe.
Okay.
In fact, we had published one paper from our own institute where it was we did a biopsy then, because we were not sure. That was at 3 months, and it came as a pseudogranuloma, and Surgicel granuloma it ultimately turned out, and we just kept under observation.
Yes. So
Surgicel can give rise to this kind of the effect post-operatively.
I agree with you. So that's the same thing, because we were also, from this case onwards, we have stopped using Surgicel bolsters, and we are very sure, because we reviewed the whole histology. We also made sure that what was the Furman grade and everything. So we asked the patient that, we told the patient that it's very unlikely that it's going to be an recurrence, and it's very likely that it's going to be an bolsteroma. So what next? We asked the patient to wait for some time, at least 6 months, and then we repeated an CT. And as you can see, the collection is still persistent, but the nodular lesion that was seen over there, that has completely disappeared. It was not exactly 3 months, but it was approximately 2.5 months from there. So just the collection is persistent, and it's a clear collection over there. So similarly, as the PGI group has published, we also published the same thing, and it has been nicknamed as bolsteroma. So from there onwards, I see that majority of the surgeons have stopped putting in bolsters after rhinography before taking in the second layer, because that is the reason why many a times the bolsters will present as an enhancing mass, and which might sometimes mimic as an AV malformation or sometimes a recurrence as well.
I mean, using bolster or no bolster would be a personal choice. I think the message is you should not repeat at 3 months and get confused that it's a recurrence, especially if your margins are negative.
That is true, yeah. So here also actually we wanted to repeat it, because the patient was insistent, because on the other side he wanted to get it done. So as we have got 7 minutes more, I'll go to the 4th case. Is it okay, Dr. Ravi? Yeah.
We finish in time, that's it.
We'll finish it fast, yeah. So this was an 48 years old male, right-sided lower polar mass. It gradually increased in size. So ultimately, so this was the situation, that it was a large lower polar exophytic mass. The patient underwent a right-sided robotic nephron sparing surgery, 6.5 centimeter tumor. The final pathological stage was PT1B. So this was an follow-up CT scan, now not at 3 months, but the CT scan was at 8 months. And as you can see, they have again reported the same thing, that they have reported it as an enhancing mass, and you can see something over here as well. So among these 3 possibilities, I would like to ask the panel, what are the possibilities? This is 8 months down the line after robotic partial nephrectomy.
It's an arterial phase image, and you can clearly see some enhancement with the aorta seen. So it looks like AV fistula to my mind.
Yeah. So we, rather than going immediately for an CT angiography, we decided to do an Doppler, and that Doppler was clear cut showing an AV fistula at that point in time, and then the thing was embolized. So we can stop here.
Yeah, you can stop here.
Thank you very much. Thank you, panelists, for the
Thank you.
participation.
Thank you.
We go on to the next session. Dr. Anuj, you can start with, because